and in obesity. At least 50% or at least 50% of eligible persons receive drug therapy and counseling, including glycemic control, to prevent heart attacks and stroke. And the last one is an 80% availability of the affordable basic technologies and essential medicines, including generics, required to treat major non-communicable diseases in both public and private facilities. These things tend to be a bit wordy, but let's focus on the last two. So 50% of eligible persons in Jamaica, for example, or the Caribbean, receive drug therapy and counseling to prevent heart attacks and stroke. And 80% availability of the affordable basic technologies to prevent non-communicable diseases in both the public and the private facilities. My question that I would pose to audience and my colleagues is, how practical are these targets within our region, within Jamaica, within the Caribbean, and beyond that as well, especially the last two? 80% availability of basic technology to everyone, private and public facilities. Okay, so let's talk about some strategies for improvement. We can employ some of the best practices that work for all NCDs, for all non-communicable diseases, and for cardiovascular diseases specifically, and stroke. We can improve awareness. So stroke and cardiac health awareness education, we can provide or improve this. We could create and strengthen stroke surveillance activities. We could create and or strengthen home assessment for survivors of a stroke. We could create and or strengthen mobile rehab services. We could work on eliminating the stigma around stroke, and we could eliminate the notion of stroke as an inevitable, my apologies for the typo here, inevitable consequence of aging. Now I'm going to pose to the audience and or colleagues, are there other strategies that we believe would work for our country, for our area? What are other ideas that we could come up with? The World Health Organization has asked us to put on a big show, 50%, 80% availability of technologies in public and private facilities. Can we do that within our region? These are some of the resources that I've used for this: the National Institute of Health, obviously American Heart Association, American Stroke Association, Hopkins, Centers for Disease Control. The World Health Organization obviously is a plethora of great information, Pan American Health Organization, Jamaica Stroke Alliance. I just want to mention here that the Jamaica Stroke Alliance was inaugurated in 2020, and it is, from what I have seen thus far, one of the only ones in our country that is doing surveillance at the national level and working with partner agencies to develop a surveillance system and a system of improving healthcare and management of care around stroke. Obviously, the World Bank information is always important, and the World Stroke Organization is extremely important. Additional resources is Hearts in America. Hearts in America is a program where now 22 countries that have collaborated with PAHO, which is a subsidiary of the World Health Organization. I'm not sure why Jamaica is not a part of that yet, but we should look into well, I don't know if we are going to be a part of it, if we're working to be a part of it, but it would be nice to see our island as part of this Hearts in the Americas program. So I've used some of the information from their technical package and obviously the United Nations Sustainable Development Goals as well, and global action for prevention and control of non-communicable diseases, which is what we had seen from the targets. And that is the end. I will take any questions or discussions as arise.
Thank you so much, Marsha.
Thank you.
That was a very informative presentation related to stroke. And we have a comment here from Dr. Thompson. He said, thanks for presenting and exploring the barriers on this important health issue, Marsha. Carlene, are there any questions from YouTube?
So far, we haven't had any additional so far.
I just like to, thank you, Carlene. I just like to stress some of the points that Marsha made, especially about the factors, the ones that we can modify, such as diet, exercise, to decrease our risk for stroke. Marsha, could you just go over those modifiable risk factors and also the signs and symptoms of a stroke? Because many times people are having stroke and they don't even realize that they're having it. So I think those simple, they seem simple, but they can save our lives. So could you just review those again for our audience?
All right, which one would you like for me to do first? I can do the modifiable risk factors, or I can do the symptoms. Let's do the symptoms first, as it appears first in the
you can do the be fast, whichever one comes first in the presentation. I think you can go over that. Thank you.
Okay, my pleasure. All right, so these are the symptoms again for a stroke. We have sudden numbness or weakness, especially on one side of the body. We have sudden confusion or trouble speaking or understanding speech, understanding languages or language as is normally spoken to us. We have sudden trouble seeing in one or both eyes, sudden trouble walking. We have developed dizziness, loss of balance and or coordination, and sometimes a very severe headache with no known cause. So these are some of what we call the classic symptoms. The be fast. Now, obviously, the rapid awareness of these symptoms is critical to preventing permanent injury or death from a stroke. Balance is a person seeming to be uncoordinated. They're not balanced. They can't walk in a straight line. They've developed a sudden lack of coordination. Eyes, do they seem to have lost vision? Do they say that they've lost vision in one or both eyes? The face, is there a noticeable unevenness about the face? Is there a droop? Does it appear that there is a droop to one side or other of the face? The arm, can they stretch out their arm without one appearing to be weak? So do they seem to have weakness in one of the arms or both? Do they have difficulty speaking? Do they have difficulty understanding speech? And if any or all of these are apparent, obviously we want to be able to get them to the emergency services as soon as possible. So those are the signs that we should look for, and that's the response that we would like. Immediate, call the services, call the emergency services, and get that person to whatever help they can get as fast as possible. As far as the modifiable risk factors for stroke, obviously, if you have high blood pressure, it's something that should be managed, obviously, with a primary care physician, if that is available to you, a clinic, but manage your blood pressure. High cholesterol, manage your high cholesterol. Make sure that you use whatever is at your disposal, medical care, clinic care, medical intervention, diet to manage that high cholesterol. Smoking, do not smoke. Do not start if you do not smoke. If you do smoke, get help to stop. Cease smoking. Diabetes, obviously you want to manage your diabetes and the symptoms of your diabetes with your physician. Your diet, if it's not healthy, if you believe it's not healthy, if it's high in sodium, high in salt, try to reduce your intake of salt. Try to eliminate it if you need to. Obviously, eat have a diet which is higher in fruit and vegetable and lower in trans fat, especially trans fat. But we also want to lower our intake of salt, sodium. Physical activity, we always want to improve our physical activity. We want to maintain a healthy weight. The goal isn't to be thin, it is to be healthy, to have a healthy weight for our size, for our height. And so those are the risk factors that are modifiable. They may help us reduce our risk. Nothing can completely eliminate a risk, but you can reduce your risk factors for a stroke or any other cardiovascular disease by taking on some of these. The non-modifiable risk factors, there's nothing we can do about our age. Obviously, we were born one or another gender, so there's nothing that we can do about that or what we were born. And obviously the phenotypic manifestations thereof, or race, family history of non-communicable diseases, and whether or not we have had a prior stroke. Once we've had a stroke or a TIA, we can't go back and undo those. So these are non-modifiable risk factors. As I said earlier, we could try to reduce our risk of getting a TIA to begin with, or a stroke, but we cannot, once it happens, we cannot modify, we can't change the fact that that happens. And having had a TIA or a stroke is sometimes a risk factor for having another. I'm just going to go again over the World Health Organization and CDC recommendations for high blood pressure. May control your goal. Now, they don't say how, but obviously through your medical intervention or diet or exercise for high blood pressure. Cholesterol, work with your doctor on a treatment plan to manage your cholesterol. Diabetes, obviously you want to work with your doctor on a treatment plan to manage the diabetes. Smoking, don't smoke. If you do, get help to quit. Unhealthy diet, again, lower your salt intake, trans fat. Higher, make sure you eat more fresh fruits and vegetables if they are available to you. Physical inactivity, if you're getting less than 2.5 hours of exercise, moderate exercise a week, try to improve on that. And weight, manage your weight. Try to maintain a healthy weight for your height. And so those are the controllable risk factors. Those are the modifiable risk factors. The others, we are not in control of, unfortunately.
Thank you, Marsha. Yes, so we do have some control over
we do
whether or not we get a stroke. And Marsha mentioned high blood pressure, management of high blood pressure. There are some medications that we take for high blood pressure that can, inhibit our function in some areas, and especially among men. Many of our men do not take their high blood pressure medications because they interfere with, with virility. Nowadays, we have medications that are targeted. Please report these interferences to your doctors. Talk to your doctor about the fact that the medication is interfering with your sexual performance. They can change it. There are many choices. Medications can be targeted for you specifically nowadays. So because we have the technology, please talk with your doctors, have a conversation, because as you can see, high blood pressure is one of the biggest risk factors for a stroke. And many people are walking around not knowing that they are suffering from high blood pressure. Cholesterol, that's another big deal. Make sure, because there are fats and fats and fats. Many times we say, okay, olive oil is the best, but if you look at the cholesterol content, or not the polyunsaturated and monounsaturated content of olive oil, sometimes it's not the best. So we need to make sure that we're checking to see what is in our food, what is it that we're eating, what is it that we're consuming that can place us at risk. Physical activity, again, in all spheres of life, physical activity really works to protect us against many diseases. Thank you, Marsha. I think we have some more questions, so I'll go to that. Can we have, let me see, based on the barriers and targets, what can the diaspora do to assist Jamaica?
I thought about this for a long time, and when I was devising this presentation, I kept going back to the one that about barriers to care, barriers in our island. Let me try to get back to that if I can. Let's see, here we are. The barriers that we have. And These are the barriers
Mhm.
that is identified in the scientific literature on stroke. And this is for low income and middle income countries. Remember that Jamaica is now considered an upper middle income economy. Still, we are a middle income economy nonetheless. And so we have the systems barrier. We have hospital facilities, inadequate access. We have limited rehab facilities in places where people are, have easy access. We have very limited access to follow-up care. We have few surveillance activities. And at the caregiver level, we have people who are not as experienced or people who are not experienced in managing someone who has suffered a stroke. We have limited resources in terms of how much money they have to take care of someone who has had a stroke, or how much money does one have who has had a stroke and is trying to take care of him or herself. And sometimes we have an inability to be able to access these rehabilitative care. And then when you intersperse that on some of the targets that the World Health Organization or other bodies have suggested, 80% of availability of basic technologies and medicine in public and private facilities. My question would be, how practical is that in the context of a middle income economy? How practical are these? What can we do? That is a good question. I cannot answer that. I can only say that I do hope that we can work together as a diaspora to build the capacities on our island. I mean, if we have people, one of the things that people complain about is that they just don't have rehab facilities. I'll just interject a little bit of personal information here. My father passed away from stroke in 2021 in the middle of the pandemic. I believe he had what seemed to have been a TIA. He lives in Portland, my favorite parish. My grandmother, his mother, his beloved mother, my beloved grandmother, we live in the area called Rose Hill Gap. It is absolutely stunningly beautiful. It is at the foot of the Blue Mountains. He had a TIA, so it means that he had to get down to the closest hospital was Anato Bay Hospital, I believe. He was sent home a day later with what they said was a negative MRI. Within 3 weeks, he had passed away. Within a week of that, we had him down to St. Margaret's Bay in a rehabilitation facility because we thought he had had a minor stroke based on the information from the Anato Bay Hospital. And it turns out when he got to the rehabilitation facility, they said that his care was too much for a rehab facility. So he was sent to Port Antonio Hospital, where he passed away within 3 weeks. Now, my father, like Dr. Frey had mentioned, was a man who was concerned about his virility in the sense that he did not want any medication that would make him what he considered less of a man. But he was someone who was very much concerned about his blood pressure. He tried to eat well. He was exercising. He was in otherwise great health. What were the sets of circumstances that then precipitated his, what I would consider untimely death? Is it lack of follow-up care? Is it lack of experience of his caregivers? Is it the fact that there was a pandemic at the time, the hospital had to discharge him? Is it the fact that there was no assessment thereafter? What sets of systems are there for persons like that? And there are lots of people in Jamaica living in the same types of circumstances. They live in rural areas of the island. They may have had a stroke or even a TIA. They may have no follow-up. They may have no care thereafter. They may not have access to a hospital facility in a timely manner. And these are the things that, as an island with a lot of rural parts to it, with a lot of people living in rural parts, that we have to deal with. So inability to provide or to get access to rehabilitative care, inadequate access to hospital facilities. Are these some of the things that we can work on as a group, as a diaspora, to improve stroke care? I mean, and the other, another thing that I thought about was many people in our island and beyond see stroke as almost an inevitable part of growing old. Many people I know in Jamaica have had a stroke. My own grandmother's had a stroke. She had a TIA. I know many people have had a stroke. It's almost an adult rite of passage, the way we think about it. It's almost inevitable. We need to remove that from our culture, our national culture, that stroke is, well, you know, the person was kind of old, he was old or she was old, not taking care of herself or himself, too much salt, had a stroke. And we need to also remove the stigma of had a stroke as if it's a death sentence. It is another, it's a serious medical condition which can lead to death and permanent injury, but we need to treat it as something that is manageable, either through modifying our risk factors for it or providing the care that is necessary once someone does suffer a stroke. How can we manage our hospital facilities? That's a large task, but we can do other things, perhaps better follow-up care for persons who have had stroke, better surveillance activities, maybe in-home care. That might be a tall order, but these are some of the things that I think the diaspora as a group with experience, expertise, passion can start to work on.
Thank you, Marsha.
Thank you.
In addition to what you've said, I think education, more than anything else, is going to be one of the major ways of treating, you know, helping our caregivers to treat patients who suffer from stroke in Jamaica. So someone asked, can we have designed basic training for caregivers in Jamaica? Yes, that's exactly what I'm talking about. We need to, you know, leverage the expertise that we have here and see how we can partner with our fellow Jamaicans to educate caregivers at home. So, you know, education is definitely a part of it. And that's why we're doing this webinar today. That's one reason for this. More comments. Medication compliance for blood pressure seems to be hard to achieve, especially among males. Do you have any recommendations? And I think we've talked about that earlier. We're kind of running out of time, but yes, it's just a matter of communicating what's happening, because many men, when they are not performing in that area, they don't want to talk about it. You know, they hide it and they just stop taking the medication. But I think a big part of it is communication and trust. They have to trust their doctors so that they can talk to them. Trust your significant others also, and let them know what's going on so that they can point you in the right direction.
I think also medication compliance comes down to a matter of, can they afford the medication? Is it available for free, or is it available at reduced cost? I do know of people.
That's a great point, yes.
Who they're cutting the medication because they're trying to, what we call, stretch it. These are not,
yes.
This is something that we have to work on. There are people that just don't have access to that clinic or wherever they have to go every 6 months. They just, they can't do it. And so what they'll do is cut the medication and stretch it. And they'll eat a little bit of callaloo because they were told that it's good for their blood pressure. So they'll mix and match what they can do. We have to move beyond that. I understand that these folk remedies are, you know, good. They're not terrible. Callaloo is a good thing to eat. However, it isn't enough to help you with your blood pressure when you do have
other things going on.
Yes, have underlying, right, and comorbid
comorbid conditions. Yes. Plus, some people, instead of going to the doctor, they take their neighbor's medication or their friend's medication.
That happens
which
as well.
May not be for them.
It's not
appropriate
for them, of course.
Yes. Comments. Marsha, thanks for a very on-point presentation. That came from Joan. Thank you, Joan.
With pleasure, Joan.
Sandria, public education on prevention strategies. The practitioners, especially in the public spaces, are grossly limited in time for patient teaching. You are so right.
Absolutely.
Yes. Another comment. Thanks for your response to my question. We contribution, Marsha, this issue can be explored further during the upcoming health summit. Yes, that's from Dr.
Absolutely.
Thompson.
We
Definitely.
should. Definitely.
More comments. We need stroke management centers. Yes,
We
definitely.
do. We do.
Can you
And
just
that's
mention, can
on
you
the
just mention
systems
the
level.
summit?
Yes. Thank you, Carlene. Let's mention the summit will be held in Toronto, Canada. It's a health summit being sponsored by JD Tan and especially the JDHTF, which is the Jamaica Diaspora Health Task Force. And it's going to be held at George Brown College in Toronto, Canada on between August 29th to 31st. So please plan to be there. It's going to be life-changing, and it's targeted to the diaspora, of course, and particularly Jamaicans. So please come, please support us. We hope to have experts in different areas. We will also have tours to state-of-the-art facilities where permissible. Because of COVID, we have to be careful, but this is going to be in person. And George Brown College is a waterfront edifice right there in downtown Toronto. So, it's well located. Please, again, plan to attend. Thank you. Thanks, Carlene, for reminding me about that. We need stroke management centers in Jamaica. Everything goes to the General Emergency Department. Stroke specialists are needed. Yes,
Absolutely.
definitely. I think it's 4:01. Is our time up, Carlene?
We are at the border. We really are. This has been wonderful.
We have some more comments coming. I think we're going to take the last comment and then we're going to go. Dorothy Brown says, great informative presentation. Thank you all. Thank you, Marsha. Thank you, Carlene. This was amazing. This was, we really should have done this last month because, we're trying to follow the calendar of WHO, but it's never too late for a discussion or information on stroke because it is such a common phenomenon and so many people are walking around and they're time bombs for stroke. Again, guys, please talk to your doctors, listen to your body, watch out for those signs and symptoms, be fast, all right? You may have some drooping, some weakness, don't ignore them. Your body is speaking to you. Absolutely. And our body, just listen to your body and follow up. So thank you all for joining in, and we will see you at the next Jaminar, which will be on the 29th of June. And that one is related to mental health. Thank you again. Have a great afternoon.
Thank you. Bye-bye.